Hello everyone. Today we are going to see about etomidate, which is an induction agent. So in this drug, we only have some 5 to 10 points which may be asked as an MCQ points. So this will be a very short lecture. We'll see about the slides. So it was introduced in the clinical practice from since 1972. So it has been in the clinical practice, the anesthesia practice for a long time, but it has gone out of favor in the earlier days. Now it is making a comeback. Previously it gone out of anesthesia practice because of its adrenal cortical suppression. But now what they have found is it is very cardiostable, meaning it does not make any fall in blood pressure, or it does not reduce the contractility of the heart. So in patients with cardiac ailments like cardiac failure, or patients who have severe mitral stenosis, severe aortic stenosis, so in these patients we don't want the BP to fall, we don't want the cardiac contractility to reduce. So in these patients the etomidate is the drug of choice. So it's making a comeback in anesthesia practice in current days. Now we'll see some of the basic physiochemical characteristics. So it is an imidazole derivative. This could be asked as an MCQ point. And hydrophobic at physiological pH. So meaning is hydrophobic at physiological pH. Meaning is, so it becomes water soluble. It becomes lipid soluble in physiological pH, but in outside when it is kept in a container, it is water soluble. So it is like midazolam. Midazolam is also a drug which is water soluble outside the body and lipid soluble inside the body. So that dual pH activity will be seen in midazolam. Like midazolam, etomidate also shows that property. To increase its solubility, it is formulated as 0.2% solution, either in 35% propylene glycol or in a lipid emulsion. Meaning, so the drug comes in a concentration of 0.2%. So we already seen in many previous lectures that the percentage of the drug means the amount of the drug in the 1 ml of solution. So for example, if it's 0.2%, you multiply it by 10. So it is 2 milligram of drug will be present in 1 ml of the solution. So that is the meaning. And it comes in propylene glycol or lipid emulsion. So propylene glycol is one of the preservatives. It is one of the formulations. So this is colorless. But lipid emulsion is like white milk. It is like propofol. Most of you would have seen propofol. So propofol will be like white milk. It is also called as milk of sleep. So this 35% propylene glycol, it comes in a colorless form. The importance of this form is because it will cause severe venous irritation. So pain on injection will be severe in this form of etomidate. So to reduce that pain on injection, what they did was they made the etomidate into lipid emulsion form. So after it has been changed to lipid emulsion form, the pain on injection drastically reduced. So in those patients, so this is also an important MCQ point. I've seen questions like which causes most severe pain on injection. The answer there is the order there is propofol. I'm sorry, etomidate, propofol, then your thiopentone. Thiopentone is not so venous irritant, but some patients may complain. Diazepam will cause venous irritation because it is an oily preparation, and it acts on GABA A receptors. So we know most of the induction agents will act on GABA receptor, and it will suppress the nervous system. And the time of induction is 1 arm to brain circulation, that is 15 seconds. In some book it has been given as 15 to 30 seconds, but mostly you mostly you write it as 15 seconds. If a choice given between 15 to 30 seconds, then you choose that choice. Pharmacokinetics. So like any induction agent, the termination of action is by redistribution. So redistribution half-life is around 29 minutes. The initial takeoff of the initial distribution takeoff is 2.7 minutes. So within 2.7 minutes, the entire brain will be, will have the maximum concentration. After that, the concentration will start redistributing from the brain to the peripheral tissues, which are non-sensible tissues, because brain is the site of action, other tissues are not the important site of action. It is 75% protein bound. You remember this. We will have an important point regarding this protein bounding and kidney and liver failure in the later slides. So clearance is very high by liver. So it is cleared by liver, and the metabolites are excreted by kidneys, like most of the anesthetic drugs. So with increase in age, because of the smaller volume of distribution and decreased clearance capacity of their liver, so the dose should be reduced. So in extremes of age, the dose should be reduced. The normal dose is 0.2 to 0.6 milligram per kg body weight. But averagely we take 0.3 milligram per kg body weight. In elderly, we have to go for the lower dose like 0.2 milligram per kg body weight. So context sensitive half-life is lesser than that of propofol. So you might think, what is context sensitive half-life? I will give you a simple example. It is something related to continuous infusion of these drugs. So normally we give either bolus dose or continuous infusion. Bolus dose is for induction. So to intubate the patient, we give bolus dose. We intubate the patient. We make the patient induced, that is sedated. We intubate the patient. But to maintain the anesthesia, so after induction, after securing the tube, we have to keep the patient sleeping. No. So for that, what we do is we give a continuous bolus of continuous infusion. So when you give continuous infusion, so you want the anesthesia to terminate, you want the patient to wake up. So when will you stop the infusion? So that depends upon the context sensitive half-life. So for propofol, if you the infusion has been going for up to 3 hours, the time duration after which the patient will wake up, that is the infusion has been going for 2 hours 50 minutes. If you stop, then the patient will wake up within 10 minutes. Like maximum the patient will take 10 to 12 minutes, not more than that. But if you stop, the infusion has been going more than 3 hours, then the patient will take around 45 minutes to wake up. So that is called as context sensitive half-life. So this context sensitive half-life is almost similar to lesser than propofol. So if you keep etomidate as an infusion, you can cut the etomidate as very late stage of the surgery. But in propofol, you have to cut, if it's less than 3 hours, you have to cut 10 minutes before you want the patient to wake up. If it's more than 3 hours, you have to cut before 45 minutes. Now coming on to the pharmacokinetics remaining. So it is mainly metabolized by the liver and by ester hydrolysis. So this could also be asked as an MCQ question. So the drugs metabolized by ester hydrolysis. So the drugs given would be like esmolol, remifentanil, succinylcholine, and etomidate, and some other drugs. So all of the above are, so whatever drugs I told are by ester hydrolysis. Then if they given a drug like propofol, then propofol doesn't metabolize under ester hydrolysis. It is metabolized by the liver. So the metabolic end products are carboxylic acid and ethanol. So these products are excreted by the kidney. So these metabolites are inactive and they are excreted by the kidney. So that is 85% will be excreted by the kidney, and 13% will be in the bile. So in pathological conditions involving kidney and liver, that meaning the liver failure and kidney failure. So in these conditions, in both these conditions, one thing is common, that is hypoproteinemia. In liver also, albumin will be low. In kidney failure also, due to continuous protein loss, your your general protein um, content will be lower in the body. So since it is only 75% protein bound, in the previous slide we saw, no, etomidate is 75% protein bound. So more amount of free form will be there. So less number of protein will be available to bound to the drug, more amount of free form of propofol will be there. So what will happen is, in these patients, kidney failure and liver failure, even a small amount of drug will cause an increased effect. So in these patients, you have to reduce the drug concentration to very much, almost like on the lower side. So that is the importance. This also can be asked as an MCQ. Dose modification is needed in kidney and liver failure. Now coming on to pharmacodynamics. So in the central nervous system, what will happen is, it acts on the GABA receptor, that we know. It produces hypnosis at a normal induction dose of 0.3 mg per kg. So this is the normal induction dose, but the range is 0.2 to 0.6 mg per kg. And it causes decrease in cerebral blood flow by 34%, decrease in the cerebral oxygen requirement, that is CMRO2, by 45%, without altering the mean arteriolar pressure. In the beginning slide itself we saw it is very cardiostable, so it does not cause fall in systemic vascular resistance or heart rate or BP. So without altering the map, but propofol will reduce the BP. That is the difference. Propofol also reduces cerebral blood flow. It also reduces CMRO2, but it will not. It will reduce the map also, and it decreases the intracranial pressure by 50% in patients with increased ICP. In normal patients, the ICP does not alter, but in patients with increased intracranial pressure, it will alter. So if the infusion is kept at 60 microgram per kg per minute, see, taken from me, I have never seen etomidate being used to reduce ICP, because continuous infusion of etomidate will cause adrenal cortical suppression, and we don't want that to happen in a patient sitting in ICU, because adrenal cortical hormones are your stress hormones, and these hormones should be high in a patient with disease. We shouldn't suppress them. So we use etomidate only for induction purpose for intubating in anesthesia, not more than that. That too in cardio unstable patients. So etomidate induced myoclonus. So this is one other important thing. This is definitely an MCQ question. Myoclonus is very commonly seen in etomidate. It can also be seen in propofol. Myoclonus is nothing but it is seizure-like activity. Like it is not continuous, some jerky movements of the muscle. So this is due to, so normally all your muscles will be constantly under stimulation and inhibition by two systems. So stimulation is done by the pyramidal tract. The inhibition is done by the extrapyramidal tract. So the pyramidal tract, it will act on the anterior horn cells and it will constantly stimulate the muscles. So all your muscles in the body will be constantly stimulated by pyramidal system. The extrapyramidal system, the function of the extrapyramidal system is it will also innervate the anterior horn cells in your spinal cord and it will inhibit the muscles. So all the muscles will be in a relaxed state. So whenever you want to do an action, if you want to extend your hand, the flexor muscles will be relaxed and the extensor muscles will be contracted. So this is how your normal function will occur. But this etomidate, what it does is it will inhibit due to disinhibition of the subcortical fibers that normally suppresses the extrapyramidal motor activity. So subcortical fibers disinhibition will occur. So this dose dependent increase in latency and decrease in amplitude in the don't go to that point. Because of the disinhibition we will have myoclonus, but that is not nothing to worry about because it is not seizure. Etomidate also has a small potency to increase seizure, but normally it doesn't happen in clinical doses. And there is something called as evoked potential, that is that is motor evoked potential. In neurosurgeries in current practice, what they used to do is when they are operating an acoustic schwannoma, for example, when they are operating on a vestibular schwannoma or acoustic schwannoma, so that structure is very close to the brainstem. Almost most of the motor pathways and the cranial nerves are coming out of the brain near the brainstem only. So the surgeon wants to know whether he is operating only on the tumor or whether he is touching the brainstem or touching the cranial nerves. So what they used to do is they used to put electrodes on the scalp of the patient and electrodes on the peripheries of the patient. Meaning when they stimulate here, when they are close to the nerve, the particular nerve will become activated and the particular response will be felt on the periphery. For example, if he is stimulating for example a motor nerve, the spinothalamic tract and a pyramidal tract. So the motor response will be elicited through the pyramidal tract pathway near the hand. So motor response will be elicited on your hand, like hand will contract like this. So the electrophysiologist, that is a subspecialty of physiology. So the electrophysiologist will tell that, sir, you are near the pyramidal tract, you are near the hand fibers, so go away from that area. So the surgeon will move away from that area and he will go only to the tumor. So he will remove only the tumor. So this is very advanced neurosurgery techniques. So the concept, the point here is etomidate will increase these evoked potentials. So it is good for the surgeon, good for the electrophysiologist. But drugs like isoflurane, your volatile anesthetics like isoflurane, desflurane, sevoflurane, and some high concentrations of opioid will reduce the evoked potential. So in patients who are undergoing neurosurgery and when there is monitoring of these evoked potential, that is sensory evoked potential, motor evoked potential, visual evoked potential, auditory evoked potential, and SSEP. So all these evoked potentials will be better. It will be better monitored when the patient is given anesthesia only with either propofol or etomidate. Normally we don't use etomidate, we use only propofol. Volatile anesthetics is inhibited. It is not used in these kind of surgeries. Other surgeries we can use volatile anesthetic, but when you want to measure the evoked potential, volatile anesthetics are not used. I think this is an advanced concept. I'm not sure how much you would have understand, but you just remember etomidate increases the evoked potential, so it is good in neurosurgeries. So effect on cardiovascular system. So this is very important slide. Please give some attention. So hemodynamic stability mainly by its lack of effect on sympathetic nervous system and on the baroreceptor function. So it does not alter the baroreceptor function. So baroreceptor becomes intact and there is no sympathetic nervous system inhibition. Both propofol will cause. Propofol will inhibit the baroreceptor and it will inhibit the sympathetic nervous system. It has proven useful in patients with valvular heart disease, ischemic heart disease, or non-cardiac surgeries, and those with poor cardiac function. As I told you, those with ejection fraction less than 45%, etomidate will be a much more better option than that of propofol. And myocardial oxygen supply demand is well maintained. So ischemic heart disease patient, the basic problem is demand versus supply. So they will have more demand of oxygen, but their supply will be very low. And when you increase the heart rate, it will become further worsened. So in these patients, when the heart rate is stable, BP is stable, and they are getting induced and they are becoming unconscious, that is a good drug for anesthetist, because your heart is stable, your brain is stable, BP is stable. So there is a good drug. Etomidate is a good drug for patients with poor cardiac function. And no analgesic effect. So this is one drawback. Propofol has a sedative effect, and it reduces the respiratory reflexes, but there are also not much of analgesic effect. But here there is absolutely no analgesic effect, so you have to supplement with opioid. So there must be combined with opioid to prevent the hemodynamic perturbations during laryngoscopy and intubation. Along only etomidate will cause increase in BB only. So what you have to do is you have to supplement along opioid, then only the patient will have less pain. So while intubating, I think we have seen the class on intubation. So while intubating, there will be a severe laryngotracheal response. So that response will be prevented along with opiates. Now respiratory system. Not much effect on ventilation, less effect on ventilation, no histamine release. See, histamine release is seen mainly with atracurium and morphine, other opioid drugs, not with etomidate. So induction produces hyperventilation for a brief period and a brief period of apnea. So the patient will start hyperventilating for some time, and then they will have a brief period of apnea which will settle on its own. So slightly increase in PaCO2 but no change in PaO2. So there is nothing much to see here. Now coming on to endocrine effects. So this is an important slide. This is why the drug has been discontinued in the previous phase. So in 1983, Ledingham and Watt reported increased mortality among patients in ICU who received a long-term etomidate infusion. See, the point to be noted here is these patients received a long-term etomidate infusion. They didn't receive a single bolus. The problem here is it causes dose-dependent reversible inhibition of the enzyme 11-beta hydroxylase. So 11-beta hydroxylase basically is the hormone which converts cholesterol to your steroids, your corticosteroids. So the problem occurring will be decrease in synthesis of cortisol, which is a stress hormone. We don't want that to happen in a sick patient. Decrease in mineralocorticoid, which maintains BP, which maintains water balance, and decrease in formation of intermediaries. So increase in formation of intermediaries, because the pathway is inhibited in halfway, 11 beta hydroxylase. This is an important MCQ question. 11 beta hydroxylase is inhibited by etomidate, and so intermediate formation will be more. The end product will be less, intermediates will be more. Now, it is more potent as an inhibitor of steroid synthesis. We know that it is achieved in the concentration of less than 10 nanogram per ml, which is much lower than concentration of hypnosis. So the problem is this drug, the clinical concentration of this drug will produce 200 nanogram per ml, but at the concentration of 10 nanogram per ml itself, it will inhibit the steroid synthesis. So that is why we are very afraid to use this drug in sepsis patients. And adrenal cortical suppression lasts for 72 hours. So in a single bolus injection, the adrenal cortical suppression lasts for 8 hours, I think. In a continuous infusion, it inhibits the adrenal cortical suppression for a very longer time. Now, uses. Induction and maintenance of general anesthesia. So induction is very commonly used in cardiac patients, maintenance not so much. Clinical hypercortisolemia. So to treat hypercortisolemia, it can be used. I haven't seen patients. So the induction dose is 0.2 to 0.6 milligram per kg. Maintenance is 10 microgram per kg per minute. So side effects, pain on injection, I told you, nausea and vomiting. So propofol decreases nausea vomiting, but etomidate, it does not prevent nausea vomiting. So basically etomidate causes nausea vomiting. And myoclonic movements, we saw the reason, hiccups. It is also similar to myoclonic movements. So novel etomidate derivatives, that is new etomidate derivatives which are free of these side effects, but they are not in practice. So methoxy carboxyl etomidate, so MOC, methoxy carboxyl etomidate, it does not inhibit the steroid synthesis. So it can be used for long-term infusion, but it is not available in Indian markets. Carboetomidate contains pyrrole ring instead of imidazole ring. So we know it is an imidazole derivative, etomidate, but here it contains pyrrole ring. So it decreases adrenal suppression. So we want a better drug, right? So these are the Reason for these are drugs which have less side effects.